Hello, everyone. My name is Lorenzo Bopello, and I want to welcome you to this session. The Association of Future African Neurosurgeons will be giving a webinar today on the criteria for surgical management of intracranial hematoma. And our presenter today will be one of our medical students, Mr. Mutambo. And first of all, before we begin, I would like everyone else to introduce themselves. We can start with Dr. Arik Finney. Please, you can introduce yourself.
Thank you so much. I'm Ori Sidney, founding president of the Association of Future African Neurosurgeons and a member of the security team for the World Federation of Neurosurgical Societies. Nice to meet you all.
All right, thank you. Darwin, you're next up.
Hello everyone, my name is Darwin Chimba. I'm a medical student at the Copperbelt University School of Medicine in Zambia, and I'm the Director of Operations for the Association of Future African Neurosurgeons. I'm glad to be here. Thank you so much.
Thank you so much, Ezekiel. If Ezekiel is unable, we can just have Mutambo please introduce yourself.
Good evening, everyone. My name is Mutambo Poster. I'm a fifth year medical student at the Copperbelt University Endoscopic.
Awesome. Thank you so much. Xavier, can go ahead. Okay, there might be a bit of a problem. We can have Samuel please introduce yourself.
Hello, good evening, everyone. My name is David Samuel. I'm a second year medical student in Nigeria, and I'm glad to be here this evening.
Awesome. Thank you so much. Praise.
Okay, I'm Wapres, fifth year medical student from the University of Buea, Cameroon. I'm also a member of the communication and operations team at AFAN. I'm happy to be here.
Okay, thank you. Yeah, Xavier, I see the chat. Thank you. He says that he's a general practitioner from Rwanda and waiting to join neurosurgery residency. Thank you so much. The presenter, Poster, you can just go ahead and share your screen, please.
Good. Thank you very much, Larry. Good evening, everyone. I hope you're enjoying your weekend so far. As a PowerPoint states, the title of the presentation today is the criteria for the surgical management of intracranial hematomas. And the presenter is, I'm the presenter. My name is Mutambo Poster. I'm a fifth year medical student from the Copperbelt University, Michael Julius School of Medicine. So basically, this is the outline of my presentation. So first look at the introduction, revise the meningeal anatomy, we classify what hematomas are, also look at the etiology of hematomas, the clinical presentation, the investigations, the management, and also the gist of this discussion, which is the criteria for the surgical management of intracranial hematomas. So first things first, we want to define what cranial hematomas are. So these are basically just accumulations of blood within the brain or between the brain and the skull. So now we want to at least try to revise our anatomy or our meningeal anatomy, so because this is what will guide us and this is what will help us in the classification, and it also helps in the management of cranial hematomas. It's very important that you know the anatomy of the brain for you to understand what is really going on, and also it also helps in the clinical presentations of the patient, and it also helps in tailoring the management of these. So just basically trying to revise the meningeal anatomy. So basically that's you can see the blood vessels there. We can also see the arachnoid granulations there. And you can also see the superior sagittal sinus, subdural. We can see the subdural space. We can also see the subarachnoid space. Then the intracerebral tissue or the brain parenchyma. So on our next slide, we'll try to look at the classification of these intracranial hematomas. These intracranial hematomas are broadly classified into two. We've got the intracerebral, intraparenchymal hematomas, and also we've got the extracerebral hematomas. Now, extracerebral hematomas are further classified into the epidural hematomas, the subdural hematomas, the subarachnoid hematomas, and the intraventricular hematomas. So now this is just a slide showing us on how the epidural and subarachnoid hematomas look, or how they appear in someone who's been affected by these two hematomas. So as we can see, we can see there is a fracture there. We've got this a fracture there, and this is the accumulation of blood between the dura, the dura and the skull bone. And here we can see an epidural a subdural hematoma, sorry, which shows the accumulation of blood between the dura and the subarachnoid matter. Yeah. So we basically look at the different types of hematomas, and this is just an image trying to show an intraventricular hematoma. Intraventricular hematomas they are very dangerous hematomas, due to that these are hematomas occurring in the ventricles. Now you find that if blood accumulates, like as we can see here, we can see an accumulation of blood. We can see an hematoma there, right in the ventricles. Yeah, right in the ventricles. Now they're so dangerous such that when blood accumulates in these ventricles, these tend to compress on the brainstem. So when they compress on the brainstem, patients rapidly deteriorate, which may even lead to the death of the patient. Now, secondly, we'll look at the intracerebral hematoma. Intracerebral hematoma, this is a type of hematoma that tends to occur in the intracerebral parenchyma, or in the intracerebral tissue. Yeah, in the intracerebral tissue, and it's mostly due to uncontrolled hypertension that may lead to hemorrhagic stroke, or yeah. So it's mostly attributed to uncontrolled hypertension. I'll also look, thirdly, we'll look at the subarachnoid hematoma. A subarachnoid hematoma, this is a type of hematoma that is due to the accumulation of blood between the arachnoid matter and the pia mater. And it's mostly due to the rupture of an aneurysm in the circle of Willis, such as a berry aneurysm. So it's mostly due to the rupture of berry aneurysms in the circle of Willis, and it's mostly attributed to vascular malformations in the brain. And this is just an example showing, this is in theater, a neurosurgical operation was taking place, and there we can see some hematomas there. Yeah, we can see them. And this is an epidural hematoma. Now, an epidural hematoma is a type of hematoma that occurs, or that is due to the accumulation of blood between the epidural and the skull bone. Yeah, and it's really one of the most dangerous hematomas, due to that it involves the bleeding of blood from the meningeal arteries, and hence you'll find that there is a rapid growth of this kind of hematomas, and the patient may rapidly deteriorate, and that may even further lead to death. So these patients that present with epidural hematomas, they are supposed to be treated aggressively and immediately whenever you make a diagnosis of an epidural hematoma. And lastly, we'll look at the subdural hematoma. So this subdural hematoma, this is an hematoma that occurs between the subdural and the arachnoid matter. So this is mostly due to it's mostly due to the bleeding from it's mostly due to venous bleeding, and it's mostly just due to maybe trauma to the head, or due to just falling. This may lead to the bleeding from veins in between the dura and the arachnoid matter. Now we want to look at what are the causes of hematomas. So first things first, hypertension, which is one of the most common conditions. Yeah, so hypertension and controlled hypertension tends to bring about hematomas, and mostly types of hematomas that hypertension causes are intracerebral hematomas. Trauma is one of the most common causes of hematoma formation within the brain. Yeah, as we can see, you find that epidural hematomas are mostly due to trauma, and they're mostly, yeah, they're mostly due to trauma. Like in the case when someone sustains a temporal parietal bone fracture, they may um, they're likely they're likely to suffer from an epidural hematoma. Cerebral myeloid angiopathy, most probably this is mostly common in old age, as there is deposition of hyaline, there are hyaline depositions in the small arteries and arterioles that may further lead to the formation of the hematoma. Advanced age is one of them, just as I explained in the case of cerebral amyloid angiopathy. Cocaine and methamphetamines are used is also one of the causes, most especially in mid in the middle-aged individuals, because this is during this age that there is an abuse of this kind of drugs. Hemorrhagic disorders are some of the conditions that may lead to coagulopathies. People that have got coagulopathies may also tend to have hematoma formations. Neoplasms, in the case that the neoplasm is bleeding, this may further lead to formation of an hematoma. Vesicular malformations, like I mentioned in the previous slides, that vesicular malformations such as aneurysms may lead to formation, when they rupture, they may lead to the formation of hematomas. Now, we may be wondering, how do these patients present? Most of these patients, they tend to present with a persistent headache, fluctuating drowsiness. They may present with confusion, memory changes, paralysis in the side of the body opposite to the hematoma, speech or language impairment, head enlargement, which is mostly attributed to in pediatrics, mostly in children, and other symptoms mostly depend on the location of the hematoma. Now, you find that one of the most dangerous complications of these hematomas is brain herniation. So patients that tend to suffer from hematomas, they are prone to brain herniation, and some of the types of herniations which are classified based on the location at which the herniation has occurred as follows. The most common area is the transtentorial herniation, subfalcine herniation, central herniation, upward herniation, and the tonsillar herniation. And on the diagnosis for this, there are other kinds of supportive investigations that may be carried out in order for you to make a diagnosis of an hematoma. But one of them, the diagnostic investigations that can be done that may help us make such a diagnosis are radiological investigations, of which we've got a CT scan and MRI, of which in our setting we find that CT scans are, at least they're more common than MRIs. And for this for this discussion alone, I'll focus on the CT scan. Yeah, so you can make a diagnosis of an hematoma or intracranial hematoma based on CT scan result or MRI results. Yeah. So this is just an image trying to help us and appreciate how an epidural hematoma looks like on a CT scan. So as we can see, you find that an epidural hematoma is most limited by the sutures of the skull. It also crosses the fauci or the tentorium, and also follows the outer layers of the dura. It tends to follow the epidural hematoma tends to follow the outer layers of the dura. It crosses the fauci or the tentorium, and it's also limited by the sutures of the skull. So this is how an epidural hematoma looks like on CT. This is just an image also showing how a subdural hematoma looks like on on CT. So this is our subdural hematoma. So you find that the subdural hematoma itself is not affected by sutures of the scar. Yeah, yeah, and it follows the falsi or the tentorium. Yeah, as we can see here. This is just an image that will help us to help us appreciate how subarachnoid hematomas and ventricular hematomas look like on CT. Lastly, this is just a CT scan showing how an intracerebral hematoma appears on CT. So now we would wonder how are these if you find out after making a diagnosis, this is subdural hematoma that I'm dealing with. After the clinical procedure, you couple your clinical the symptoms of the patient, how the patient has presented, plus the CT scan confirm that what I'm dealing with is an hematoma. So now the management itself is divided into the general management, the medical management, and the surgical management, which is our main interest for this discussion. Now, for the general management, what do you do for this patient that is awaiting to be taken for surgery, or who's awaiting to be taken to the ICU so that they can be further be managed? So basically, you have to resuscitate the patient. You check the LTS protocol. So you check the airway, check the patterns of the airway. Yeah, so it's important that you check do the ABCs, the airway, you check the patterns of the airway, you check for breathing, and you also check for the circulation. And secondly, you check for the conscious levels of the patient by doing a Glasgow Coma scale. Then you immobilize the cervical spine, probe the patient at 30 degrees, probe the head of the patient at 30 degrees. It's important that you perform endotracheal intubation in patients it's very important that you perform an intratracheal intubation in patients that have got decreased levels of consciousness and those that have got poor airway protection. So it's very important, because in a patient that is unconscious, it is really key that you protect the airway by doing an intratracheal intubation. It's also important that in the case that what is causing the hematoma formation is due to a raised BP, it's important that the BP is lowered cautiously. At least the target should be a mean arterial pressure of less than 130 millimeters of mercury. And it's very important, as you await to transfer this patient to ICU or for surgery, it's important that you rapidly stabilize the vital signs of this patient. The BP, you make sure the circulation is there, and all the vital signs are there. You check the heartbeat, you check the pulse. So those things are really important. And as you are doing everything, this should be a team approach. It shouldn't be a one thing. This shouldn't be left to one person doing everything, but it should be a team approach. That this should be done as you are doing everything simultaneously. It's important that you also acquire an emergency CT scan for the patient, so that you know what you're dealing with as you're resuscitating the patient. It's also important that as you intubate and hyperventilate if the intracranial pressure has really increased. As you find that patients that present with raised intracranial pressure, there is the Cushing stride that is initiated, there is an irregular breathing that is there. So it's really important that you hyperventilate the patient, so that this patient does not further deteriorate or maybe die because of a compromise in their breathing. It's also important that you further lower the intracranial pressure by the administration of mannitol. It's also important that you maintain the brain perfusion by administering IV fluids, and isotonic solutions are advised in such patients, like by giving normal saline in such patients, so as you keep cerebral perfusion. These patients should be kept warm to avoid hypothermia. It's also important that if what is causing the hematoma is coagulopathy, these patients should be given fresh frozen plasma, vitamin K, protamine, or a platelet transfusion should be done. In the case that the patient presents with seizures, it's important that these patients are put on anticonvulsants to to uh, to to stop the seizures. As you find that patient who is seizing, and this is a patient who is deteriorating, and if they're seizing, these patients may aspirate if not intubate, and this may further worsen the condition of the patient. So all these measures that are done, they're just there to facilitate the transfer of the patient to the operating room or the ICU. So now, what is the role of medical management in patients that you have found that after making a diagnosis, you find out that this patient is having an intracranial hematoma. So you find that principally, you find that the therapy of medical management is mostly just focused to minimize the injury of the patient and stabilize the patient in the preoperative phase. As this patient awaits surgery, medical management can be initiated in such patients. And you find that non-surgical management of these patients is minimal. And that's why you find that non-surgical management in these patients with medical management in these patients can be done in those having minimal neurological deficits or with intracerebral hemorrhage of volumes of less than 10 mils. Now, our main interest is surgical management. So now, on the surgical management, what do you consider when you want to manage a patient surgically? So it is important that you assess the clinical course of the patient, and the timing is really important. The patient's age and any other comorbidities that may be present in the patient. It's also important that you also consider the etiological factor. What leads to this patient having or develop or this intracranial hematoma that you have discovered? And the location of the intracranial hematoma is really important in patients that have got an intracranial hematoma, because how severe or how quick you are supposed to respond as a doctor is also tailored down on the location of the hematoma. The mass effects, because these hematomas, they tend to cause mass effects such as they may bring about cerebral edema. So it's really important that you also look for the mass effects of these hematoma that you're dealing with and the drainage pattern of the hematoma itself. Yeah. So now, some of the surgical approaches for the management of intracranial hematomas are one, we can do a craniotomy and a clot evacuation under direct visual guidance. We can do a stereotactic aspiration with the thrombolytic agents. Yeah, and endoscopic evacuation can be done in such patients. So you find that, so like you can see, this is just a slide showing how a craniotomy is done in these patients that tends to have in the case that the patient is having a intracranial hematoma. So like we can see here, we see a left-sided craniotomy for an evacuation of the subdural hematoma of the left frontal and left temporal regions. Yeah. So as we can see, there is the area of the craniotomy is labeled. Then the bowels drilled into the scar of skin, and the flap and the fascia are turned down. Yeah. So we can see how the procedure is going. The scar is opened by the connection bowels with craniotomy. The dura is exposed, and the scalp flap is turned down, exposing the blood, which is removed by suctioning. Yeah. So as you suction, you're trying to aspirate the hematoma from the affected region. As we can see in this patient, yeah, there is an aspiration of the hematoma going on after doing a craniotomy. Yeah. The second type of procedure or type of surgical approach that can be done is a stereotactic aspiration with thrombotic agents. So as we can see here as we are seeing here, first there's a machinet is done, there's opening of the bone flap, then there is the aspiration. As we can see here, there's aspiration, there is aspiration going on, thrombolytic agents are done. So these thrombotic agents that they are helping in this procedure. And then lastly, it is the endoscopic. Lastly, we'll look at the endoscopic evacuation of this intracranial hematoma. So this is just basically how the uh, the endoscopic evacuation is done. Yeah. So now the gist of our discussion today, which is the criteria for the surgical management of intracranial hematomas. So first things first, we'll look for this discussion, and I only managed to find literature for intracerebral hematomas, subdural and epidural hematomas. Yeah, because these are some of the most common types of hematomas that are dealt with mostly. Yeah. So now we might be wondering, what is the role of surgery in patients that tend to present with cerebral intracerebral hematomas? As in a preamble, as I stated, intracerebral hematomas, these are affecting the cerebral parenchyma. Yeah. So now the role of surgery, you find that in this patient, in the treatment of intracerebral hematomas, remains a matter of debate. It's somehow controversial. So it's controversial to manage patients surgically for those intracerebral hematomas, in that you find that these hematomas are caused by direct damage to the brain. So this is one of the reasons of the debate, and usually surgery does not restore the function of the brain tissue when it dies off in this after doing a craniotomy or any surgical approach. It does not restore brain function because mostly damage occurs directly to the brain. And these hematomas, they are within the brain tissue. So meaning, as you do the surgery, you tend to remove the overlying brain tissue, or maybe viable brain tissue, which may further worsen the brain function of the patient. Yeah. So these are some of the reasons why surgical approach in the management of intracerebral hematomas is somewhat controversial. But some study was done in which an international trial was done on intracerebral hemorrhage, and some of the eligibility criteria for the management of intracerebral hematomas was that for someone to be eligible, it's very important that you assess this patient, and for the surgical approach to be initiated, someone should present with an intracerebral hematoma within 72 hours of ictus, and this hematoma has to be operated, or the patient has to be operated on within 96 hours. The clot, so the size of the hematoma or the clot itself should be more than 2 centimeters in diameter. Yeah, should be more than 2 centimeters in diameter, and the clot itself, when in terms of location, should occur in the supratentorial region. I may just go through that again. The criteria, an international study was done in which trials were done, and they advised on the eligibility criteria for in the surgical management of intracerebral hematomas. And a consensus was reached that a patient who presents within 72 hours of ictus should be operated on, these hematomas should be operated on within 96 hours, and the size of the clot or the hematoma should be 2 centimeters more than 2 centimeters in diameter, and the location of the hematoma should be mostly in the supratentorial region. Now, some of the recommendations that were done after these trials for the surgical removal of these intracerebral hematomas are as follows. So one, the patients with a cerebral hematoma who's deteriorating neurologically, a surgical approach can be done. One of whom you assess that they are having brainstem compression, one who presents with hydrocephalus due to the obstruction of the ventricles, one after doing your diagnostic investigation, you find that the location of this hematoma is in the supratentorial region. Yeah. So now you find that the early hematoma evacuation in someone who's got intracerebral hematoma is quite not really beneficial. Yeah, in these patients. So a decompressive craniotomy, or with or without hematoma evacuation, might reduce the mortality for patients with the supratentorial intracerebral hematomas. As like we said, the location mostly in the supratentorial region. Its supratentorial region itself is really a dangerous region because patients that present with hematomas in this region may further deteriorate or may die due to brain herniation. So that's why the location is really important. That's why a decompressive craniotomy may be of help in such patients, so as to reduce mortality or reduce further complications. So now we're going to look at the epidural hematoma. The guidelines for the surgical management of epidural hematomas, I got the guidelines for the management for the surgical management for subdural hematoma themselves were according to the guidelines for the management of traumatic brain injury, and they recommended that patients who exhibit an epidural hematoma with a volume of greater than 30 mils should undergo surgical evacuation regardless of the Glasgow Coma scale score. And you find that this criteria is really important in that patients who tends to exhibit the thickness of 15 millimeters or more is also eligible for surgical management. Someone who presents with a midline shift of beyond 5 millimeters. So these guidelines are mostly tailored to the size of the hematoma. They're mostly tailored to how big the hematoma is. So these are the guidelines so according to these guidelines, are mostly based on the size of the hematoma. So you find that most of these patients with epidural hematoma, they tend to experience worsening complications such as worsening conscious states. Yeah. And the other criteria that we're going to look at on the surgical management the criteria for the surgical management of epidural hematomas is tailored down to the location of the hematoma. Yeah, like I said, the location is really important. So location is really important in that those hematomas occurring in the temporal region, if in the case that they are large or they expanded, these may lead to herniation and more rapid deterioration. And an epidural hematoma occurring in the posterior fossa, which this is often related to interruption of the lateral venous sinus and often requires prompt evacuation because of limited space available compared with the supratentorial compartment. And lastly, we will look at the subdural hematoma. So for the subdural hematoma, the criteria that was used, this is according to the Brain Trauma Foundation. The criteria that we're going to use for subdural hematoma is according to the Brain Trauma Foundation and the Congress of Neurological Surgeons 2006. These are the only guidelines. I couldn't find any latest guidelines. Yeah. So these are the only guidelines that I could find, the ones that were tabulated in 2006. So according to these guidelines, these guidelines state that there have to be immediate decompression in a comatose. There have to be immediate decompression in a comatose patient with an acute subdural hematoma of less than 1 centimeters in thickness, causing a midline shift of less than 5 millimeters if any of the following criteria are met. So when the following criteria are met, such as one having a Glasgow Coma scale that decreases by 2 or more points between the time of injury and hospital evaluation, one in which the patient presents with fixed and dilated pupils, one with an intracranial pressure that exceeds 20 millimeters of mercury. Yeah, so those are my references, and I've come to the end of my, so those are my references. Yeah, and I've come to the end of my presentation. Thank you.
Thank you so much for such a marvelous and elaborate presentation. I think we've learned a lot, and I think I can open the floor for any questions, discussions, comments. Anybody can just chip in. This is a really great presentation. Thank you so much.
Thank you very much for the opportunity.
Any comments?
Hi. Thank you so much for such a detailed presentation, Poster. I really like the fact that you took the time to. It's clear that you did a lot of reading. And you took the time to present this information in a, I would say, digestible way, and it was equally obvious that you understood what you read in most aspects. So I would say for a fifth-year medical student, this is really a quality presentation that would be expected from a junior neurosurgery resident. So really, you should be proud of yourself. Congratulations. The next I'll say is,
Thank you very much.
when going forward with your presentations, you should try not to dwell too much on a point or repeat yourself. If you can cut that out, I think you can gain a lot of valuable time, right? So sometimes you said something and then you stayed on that point for a bit. But besides that, I really like the presentation. So great job. We look forward to seeing you present more of these quality presentations here.
Thank you very much.
Awesome. Thank you. Any other comments? Anyone? Well, I personally think that this was a very interesting presentation. I mean, I'm just a third-year medical student, and there's a lot that I do know about the details of the management. I think we'll be dealing with that in fourth year. So I think this is a great learning opportunity for me. If there's, yes, Marvin?
Yeah, hi everyone.
Hello.
Hello.
Thanks for the good presentation. Well, I have some issues about regarding the the indications for surgical management of intracerebral hematoma. I think you've mostly focused on the stage 1 trial. Well, there have been, after the stage 1, they did a stage 2 trial and many other randomized controlled trials. And in 2015, I think the American Heart Association and the American Stroke Society, American Association of Anesthesiologists brought out some recommendations based on about 10 randomized controlled trials.
Okay.
Well, for intracerebral hematoma, the most the indication were this volume of the hematoma first, considering the location. If we are supratentorial, the volume of the hematoma greater than 30 milliliters, and also the location like within the parenchymal, if it is within 1 centimeter of the cortical surface. Though this recommendation, this 1 centimeter, this position changes with the type of surgery, like for stereotactic evacuation of the hematoma. You can do deep, you can remove deep hematoma with the stereostatic technique, and also with endoscopic technique. For the supratentorial hematoma is, as you said. So I just wanted to precise that.
Thank you very much, Marvin. Thank you for your recommendation. Thank you very much.
Thank you. Thank you so much. Yes. Anyone else have an addition?
If I may add something again,
No
this is
problem.
a, well, you mentioned for the, during the presentation on the medical management, you mentioned phosphenitoin for the treatment or
Yes,
prevention of seizures. Well,
yes.
I would like to know the evidence behind that, because now they tend to not to do prevention of seizures, or not to give anti-epileptic drugs unless the patient present one episode of seizure. So I would like to know the evidence behind
Oh,
that.
oh, okay. Okay, let me just, okay, the route that I was using was from Medscape. Yeah, it was from Medscape. So that's what Medscape was saying, that you have to give phosphophenitoin. Yeah, and you also have to manage the seizures. That's what Medscape was telling me. Yeah, that's what Medscape. That's why I've also put the references at the back. If you saw my presentation, I cited Medscape. Yeah, so that's why I got that.
All right. Thank you. Thank you so much. Any other comment is welcome. All right. So if in the absence of any comments, I just want to thank everybody for attending, and I hope the next webinar will also attend. Thank you so much, everyone.